Next slide, please. So I think somebody is having a lot of disturbance somewhere in the line. Okay, fine. So this case slides have been actually given by Roche. I have some of my own cases, but anyway, I will try to see what we can do with these cases as well. So essentially, a patient who had a CLD, decompensated liver cirrhosis, which is alcoholic, presented with lesions found on ultrasound and high AFP 1900. So patient did undergo a biopsy in this case. But before that, if I can start off with Dr. Nitin, would you want to do a biopsy in such a patient where there's a clear-cut CT MRI finding, or do you do it routinely in those patients with low AFP?
So my practice is generally I rely on the radiological criteria, and if that is supported with AFP, so generally I don't do a biopsy if the patient is directly resectable, if it is for surgical point of view.
What about if the AFP is normal, but still radiologically it's pretty much a standard with the LR3 or LR5 or something if they give the
there are
report?
scenarios where AFP can be normal and the imaging might be suggested. In that scenario, generally, if there is a dilemma, then only and if the patient does not have any features of chronic liver diseases, that is risk factors like hepatitis B and C, then in those cases, I might consider doing a biopsy. But otherwise, generally, biopsy can be avoided in most of these cases. Hello?
And at least by now, I was saying that generally that's our approach for everybody. That's what we are doing. And definitely the radiological imaging is much, much better nowadays, at least in a very high volume center, especially the radiologists are pretty good at picking up the LR5 lesions nowadays. Next slide. So these kind of patients with a confirmed HCC, what are the factors that we look for when we are starting any treatment? So before going to the intervention radiologist, can I just ask Dr. Alpesh and then Dr. Ankit, what do we look for in any patient who has presented with HCC? And do you see any of the earlier HCCs at all nowadays? Dr. Ankit, Dr. Alpesh?
Okay, I am Dr. Alpesh. Yes. First of all, we should see the underlying liver function, whether it is HCV seropositivity status, HCV or HBsAg positive or not, and the tumor extent in number and extent both. And there is any portal whether invasion is not or any extrahepatic spread is there or not. So based on all these factors, including also performance status, treatment plan will be decided.
Okay, I think that's what, as a standard, all of us do. Dr. Ankit, how is the management decided in your center? Would you have a MDT along with the hepatologist, the liver transplant, or is it more of a patient coming to first to whomever and then treatment is decided? Dr. Ankit? Yeah, Dr. Ankit, yeah.
Good evening, Mars. Can you repeat the question?
Yeah, good evening. I was asking, how is the treatment planning for a HCC done in your center? Do you have an MDT with a hepatologist and everybody, or is it more of a individual patient coming somewhere and then deciding the treatment?
Both the scenario is there, Dr. Vamshi. 50-50 ratio.
Okay.
Because patient will come directly after diagnosis from the general practitioner as a malignancy, and 50% patient come from the gastroenterologist. For the second opinion, they are inoperable.
Okay. Dr. Dhruv Patel, are you there?
Yes, sir.
Yeah. So, Dr. Dhruv, same question. How is the management nowadays done? Do you do it in an MDT with a HCC clinic, or is it again kind of it comes first to you? You go ahead and plan your surgery, or do you take the opinion of an intervention radiologist in every case? How is the general practice?
So it depends on the patient performance status and tumor characteristic, mainly the number and size of the tumor, and the other radiological feature like the tumor invasion present or not. And if operable, need of the interventional radiology is not there in every case, but if the borderline case, we should involve the interventional radiology for the discussion of the management.
Okay. Dr. Rosal, your thought on this?
Yeah, basically we are never the patient never comes to us directly. Good evening, everybody.
Good evening.
We are generally referred by the medical oncologist, the surgical oncologist, and once seeing the case, we discuss with them about the possible options. So basically, we what we get is the non-resectable cases, medically or surgically non-resectable cases. And if
Okay.
there is portal vein thrombosis, if the bilirubin is high, if the coag profile is bad, uh, then we discuss and treat them accordingly.
Okay. So again, I think the whole thing, this is a general practice. And to be honest, even before I joined my present center, we were doing like that. A present center does have a much higher volume, and at least we are trying to integrate and start a HCC clinic. So, the need of the hour, what we feel is to start the HCC clinic because that's where all the combined modality discussion can be done. Next slide. So this is the patient diagnosis where it was seen that this patient has a childhood BCLC-A, childhood A5. AFP is very high with lesions which are there. So if it is a childhood A, if patient cannot undergo ablation or a transplantation, what would be the next option? That's just what I wanted to ask everybody, and then your opinion. So, Dr. Dhruv, what would be the option? Patient cannot undergo resection for any reason or cannot undergo transplant. What would be the next option?
So for these patients, resection is an option. The patient performance status is good.
So, where are the places where you would not do a resection? Let me put it that way. BCLC-A, any case where you wouldn't be doing a resection?
Yes, almost in every case, if the based on the tumor characteristic, the number and the location of the tumor and the size of the tumor is amenable for the resection, we can do the resection, sir.
Okay. So, Dr. Rosen, the same question to you. Where would you suggest a TACE? And what's your thought on this new thing that is now coming in a big wave about the SBRT? Because SBRT is also something which is giving you similar results. In BCLC-B and in PVT, we are finding a similar result. We don't have a radiation oncologist in the panel today, so I can play the role of the radiation oncologist for now. So, what's your thoughts on this aspect?
Generally, for even for ablation, generally we get patients where the resection or the surgery is not feasible, and ablation is generally done in every case is by some or the other way we can ablate either radio frequency or microwave ablation if it is near the vein so that the heat sink effect doesn't occur. Even if there is a colon aborting or the gallbladder aborting, we do hydrodissection. So generally ablation is amenable. I don't have a direct experience of SBRT because I have personally not seen patients. And yeah, I know from the papers that it is coming up in a big way. Yeah.
Yeah. So it's very interesting because TACE has been the traditional thing to be done, but beyond TACE, anything else doesn't have any evidence. Microwave doesn't have any evidence that it is better than TACE. Air doesn't have any benefit in terms of a phase 3 trial. SBRT, there's been no phase 3 trial as of now. The only phase 3 trial of TAIR did not really show an OS or any other advantage. The only benefit seems to be the number of things or the response, but never any benefit in terms of the DFS or the PFS or the OS. Next slide. So for me, more important than the stage A is the decision of the BCLC stage B, where you have multiple lesions and where that's where the decision of whether to do a local therapy or not really matters. Next slide. When you use stage BCLC-B, you are actually including either some macrovascular involvement or multiple lesions. So that is something which is I would wanted to really discuss in today's meeting. So Dr. Nitin, your thoughts on a BCLC-B with multiple lesions or with a macrovascular involvement or a PVT? What is the standard option in such cases?
Hello.
Dr. Nitin, yes.
My voice is audible because of some disturbance.
Yeah, I
Hello.
can hear you. I can hear you.
So
Yeah, I can hear you.
BCLC-B, generally, I would not prefer doing surgery. I would rather abstain from doing that. Hello.
What would be your plan in that case?
So I will involve my intervention radiologist in that and take his inputs for certain procedures like TACE or TARE if it is possible. I try to take his opinion on that.
Okay. So again, you are radiation oncologist for us SBRT to the PVTT because
Yes,
that seems to be
that
one
can be one of the
emerging
options.
thing.
But for portal vein embolization, well, you told portal vein involvement. So in those cases, I would
Yes,
try.
portal vein thrombosis.
In
Portal
those
vein
cases,
thrombosis.
I would avoid getting my radiation oncologist involved. If it is without portal vein, probably yes, then we can give that as an option.
Okay, actually that's actually the other way around. TACE cannot be done if the portal vein is involved or a portal vein thrombosis is there. TARE can be attempted in that case. SBRT can be done in both the cases. So that's the reason I was
What
asking
I
you
meant
that.
was
So
tear in the cases where the portal vein thrombosis is there, we can do tear, and where otherwise TACE is an option. And SBRT with multiple lesions and with portal vein thrombosis, don't you think it will be too big a field to be covered by SBRT?
excellent. So the question we'll put to Dr. Rosel. Multiple lesions and the PVTT. What benefit is TACE in that situation? And can TARE cover all the lesions?
So what we do in this type of cases is
Hello, Dr. Rosel, you on?
just a minute, just a minute.
So why the reason? Yeah, go ahead.
Yeah. What we do in this type of cases, we do TACE in a segmental portal vein thrombosis. If there is a right portal vein thrombosis, but the main and the left is patent, we do TACE. Not we never do TACE in the patients with main portal vein thrombosis. It is contraindicated. Basically, TACE and TARE can cover all the lesions. We do lobar TACE. So we inject the drug, even the TARE or the TACE, in the right hepatic artery or in the left hepatic artery at a time. So after, suppose if I have done, there are bilateral HCCs with portal vein thrombosis, we do one session of TARE in the right lobe. We do second session after 3 months in the left lobe. So we never do both the lobes together. That's how it is.
What is the outcome in this? Because again, if you go by literature, if you go by either seven beyond seven rule or the 7+7 and 11 rule, none of these, all of these are very clear that if you have multiple lesions or large lesions, TACE and TARE are essentially incurable. So, what's your thought on that? Would you still just stick to this, or in this situation, would you want to go for some extra treatment as well?
No, generally, this treatment, TACE or TARE, is combined with the systemic therapy. It is always combined with systemic therapy. It is never a
That's nice to
standalone.
know because there's no evidence for combining both as such as of now. Again, the trials are almost negative, except for the tactics, which was positive for whatever reason. But all the trials have become negative. So, Dr. Ankit, first you and then Alpesh, what is your thought on this combination of using things? Do you support that? Or do you think we
Yes,
should add some systemic therapy?
we have now Chinese trial, Himalaya trial, I think, in which there is a lenvatinib was
Himalaya is not
combined
Himalaya.
with TACE, and there was some OS advantage, but it was only for Chinese patients. And yes, if we see guidelines, yes, we can combine lenvatinib with TACE according to this
No
Chinese trial
guidelines
result.
suggest combining. No
And
guidelines are
it's
suggesting
not there
that.
in
As of now,
guidelines, but there is one trial data, Chinese trial data is there
one
for
trial.
lenvatinib with
Okay.
TACE.
Okay. So is that being done in practice in your center? Would you do lenvatinib for TACE for all patients post TACE or for only those who fulfill the 7 and
So,
beyond criteria or any criteria that you follow?
no. If there was any extensive liver disease in which a test was performed, and this result come in September only. I think that Chinese result trial has come in September only, so this month only. So till now I have
Okay.
not
Dr.
given any
Ankit?
patient, but
Okay. Okay. Dr. Ankit?
After TACE, generally, I will not put on any medicine. The alternate unless patient biochemical failure or develop a new symptom which was not amenable for second TACE or TARE, then I will go for systemic treatment.
Okay.
Already trials
Very
are going on,
fine.
multiple
So I
trials.
think
But till date also, I am a PI of one trial, Emerald 1, in which TACE followed by Durva Beva. But from interim, I think the results are negative. So they already approved trial for Emerald 3, in which they doing a combination of an Durvalumab plus Envatinib. Now let us see what happened to that trial.
Okay, very good. I am also the one of the PIs for the Emerald study, so we did give a patient there. Let's see how it goes. So great. So I think we'll stop this session because we start discussing BCLC-B, the benefits and the demerits and merits of TACE alone versus TARE versus SBRT versus anything. I think that discussion will never end. We had almost a 3-hour session last time in TMH on the same topic. So can we just go on to the slides to the next case, please? And we'll plan for starting on the metastatic case of the HCC, which is having extrahepatic spread, so basically a BCLC-C or something that has progressed and beyond and is non-tasteable. So that category of patients is also a pretty big category. So in that situation, Dr. Alpesh, what would be your first choice? Patient has come to you with, say, periportal nodes or some lung mets, large lesion in the liver. Any role for doing local therapy in such a case?
Not at all. If patient has extrahepatic spread and major vascular invasion, in that case, systemic therapy is way to go. And for that also, we have to again assess the underlying liver function also. If patient is child 2A or B, then we can offer the category 1 indication is now Atezo plus Bev. But if it's extrahepatic spread, then it's a systemic treatment. I'm Dr. Alpesh only.
Extrahepatic is systemic. Yes, yes, Dr. I'm sorry, I was asking Dr. Ankit. I can't find him. That's why I was just asking him. Dr. Ankit, are you there? Dr. Ankit? Okay, I think he has to leave for some emergency. He just messaged me. Right, very good. So again, the interesting idea is again when you start looking at this stage 4 disease and all, Dr. Rosil, would you have see any role for doing any local therapy as well in such a case, or would it just go for systemic? Because there's a trend of thought that give the local treatment as well and then add systemic to extrahepatic. Is that something you're doing now, or is that something that is now outdated?
Generally, I see what are the number of lesions and the approximate amount of liver tissue involved. If more than 40% or 50% liver tissue involved, then I think systemic more than 40-50% liver tissue with extrahepatic disease, systemic therapy is the best. For case-to-case basis, in a limited liver lesion limited in one part of the liver, we can add TACE.
So what is the benefit of that? I mean, I'm just curious because you have 20% liver involvement but multiple lung metastasis. What are you going to achieve by adding TACE there?
Sometimes if we control the liver lesion so that portal vein remains uninvolved.
Okay. That is well, again, I'm asking this because I have tried to find data for this, but there's no data. But it seems to be an article of faith that anything in the liver has to be given a local treatment, for which there's no evidence whatsoever, especially in a setting where you have good systemic
basically, we are trying to protect the portal vein, because if the portal vein gets thrombosed, the fatality increases faster.
Okay, fine. I mean, again, I'm very intrigued by, like I said, because there's no evidence for it. There's absolutely zero evidence for doing it. So, Dr. Dhruv, the patient comes to you and you see, you do see extrahepatic spread, either in terms of nodes or in terms of peritoneal disease or in terms of bone mets or in terms of lung mets. Is there any point in doing a local therapy at all?
No, sir.
Okay. So, again, many times these patients do end up getting for various reasons. Personally, I agree with you that the PVTT still makes some sense because you could probably have some benefit by reducing the liver dysfunction if you have a PVTT being treated. But beyond that, I really don't see the advantage. But Dr. Alpesh, your thoughts on the Atezo-Bev, because that seems to be the best treatment option available. Is it something that is now a standard of care?
Yes, it is a category 1 indication and acceptable globally by all guidelines. So category 1 in first line is Atezo plus Bev is way to go.
Okay. So the Atezo-Bev trial, there are some criticisms, you cannot give it in terms of whenever there's a bleeding or something.
Yeah, so there are some exclusion criteria there in IMBRAV, like bleeding esophageal varices. In that case, we have to first control the esophageal varices. If then can give. If at all we have to omit bevacizumab, then now again we have data with tremelimumab plus durvalumab. it is the second best choice
The Himalaya.
for those patients who Himalaya trial. Yeah.
The Himalaya is sort of 1 month advantage. Is it really worth the drug? I mean, CTLA4 otherwise doesn't seem to work there. So only this one trial is working. Uh, your thought, you still go with Durvalumab because we don't have Tremelimumab in India anyway.
Because right now still second best option is that only. If patient can afford financially, otherwise Lenva will be the second choice.
What's your thought on the rationale study? The Tislelizumab also has shown non-inferiority to sorafenib. So would you consider that as a good option coming down the line? But that's a non-inferiority study, of course.
Practically, I don't have experience and I don't have choice, but I will read long-term data only.
Tislelizumab is not available again. I think Dr. Mukesh is also there as a medical oncologist. I'm sorry, I didn't see your name. I'm not asked any questions. I'm so sorry. Dr. Mukesh, are you there? Okay, I think he's not there. So very good. So the whole concept now is whether we would be doing in this CA is as a Atezolizumab for all patients. How many patients are we able to give it actually? Is it possible to give it to everybody? It is an expensive drug. Again, Dr. Alpesh.
Dr. Mukesh is there, sir. Dr. Mukesh is there.
Dr. Mukesh is there. He's not replying. So, Dr. Mukesh?
Yes, sir.
Hello. Yeah. So I was asking, what are your thoughts on the this trial, the Atezolizumab? Do you think it's become the standard of care, and how many patients actually get it?
I have no cases such. I have never used 80 plus.
Never used. So what's your standard of care right now? Yes, Dr. Alpesh, go ahead.
Yes, I have one patient. He is right now on 9th cycle of Atezolizumab with very good response. So
excellent.
only bothering thing is practically diarrhea, but it is again controlled with supportive medicine.
Okay. Great. So we actually analyzed our data in our institute. We have around 40 patients so far, and again the PFS seems to be similar to what the West has said, but what we noticed that any patient who does not have a CPS of A, if you use it anywhere beyond A, even P7 or above, the results are bad. The patients do decompensate and they don't seem to do very well. That's one thing we have to be very careful of, but otherwise it seems to be the standard of care right now. Beyond that, in second line, you have a lot of drugs which have been tried. Again, first line, we have used Pembro, we have used and we have used even Nivo, both have failed in the first line. So, firstly, the choice seems to be, as of now, Atezolizumab only. Only other thought, Dr. Alpesh, we have, what would have happened if you had used Lenvatinib as a comparator arm? Do you think that would have worked better?
There is no, I think, head-to-head comparison study, but I don't think it would have a better result, because Atezo plus Bev is the only single combination which has shows the highest median OS in first line, like 18 months.
Okay. So again, this is where we are right now. I think the first line remains Atezolizumab. Personal experience, it is quite easy to use. There are no major side effects in terms of what we normally expect with these drugs. However, definitely you are going to see some amount of decompensation in a patient who has a large liver disease, in patients who have CPS-B. I have one patient right now who is suffering from skin lesions and skin toxicity. Unusual, but that's what it is. And we did use steroids for him to bring down the disease. He's on 8 cycles. So we offer Atezolizumab to almost all the patients, though the number of patients who take it are less. Mostly in that case, we go with Lenvatinib. And the benefit of Lenvatinib is there. Again, not great, but it's what it is. So I think that's about it from my side. I don't think there's anything else to discuss. If any other panelists want to bring up any topic, I'll be happy to take it. Dr. Alpesh, Dr. Dhruv, Dr. Mukesh, if you want to discuss anything else, we can go ahead.
Okay, so before starting Atezo plus Bev in your clinical practice, how often you screen for esophageal varices? And if it is bending is done, then how will you monitor during therapy also?
So we do an endoscopy before starting for every patient. If it's done in the last couple of weeks, I don't repeat it. If any banding done in the last 2 weeks to 1 month, I wouldn't use bevacizumab. I would be a little hesitant to do it. Monitoring wise, they just come and land up with you with the bleeding if they have bleeding. Otherwise, during therapy, we don't normally monitor unless they were very large and we had to band them. I don't monitor during therapy for it. So that's what we do in our practice.
Do you have any experience post-transplant relapse patient using Immuno plus Bev.
We have
Plus
not
Bev.
used in any cases. In our patients, we have not used because post-transplant, they're already on immunosuppression, so I have no idea what it will do. We considered using for one patient. This was 2 years back. We gave nivolumab. Didn't work for only. But that was the time when nivolumab was still approved in the second line. Of course, now it is no longer approved in second line. Though surprisingly, Pembro has been approved for I don't know what reason, but that's how it is. So if anybody else has any question, otherwise I can close it and hand it over back to the organizers. Okay, so back to the organizers.
Excellent discussion, Dr. Vamshi. So we'll move to the session.